The room was colder than she expected. Not emotionally, physically.
A surgical theatre has its own climate. Air thinned and chilled to slow what lives, to steady what trembles. Pam Reynolds noticed that first. The way the temperature pressed against her skin, the way voices sounded smaller inside masks, the way the ceiling lights did not flicker but hovered, flat, white, unwavering. She was a singer, a musician, someone who listened for a living. And now, listening was the last thing she was supposed to do. They explained the risk in careful language. They explained the procedure in steps that sounded orderly, rehearsed. There was an aneurysm, deep, dangerous, positioned where ordinary surgery could not reach. To fix it, they would have to stop more than her heart. They would have to stop her brain. Pam nodded. Not bravely, not dramatically. She nodded the way people do when the choice has already been made for them, when consent feels less like permission and more like alignment with what is inevitable. Electrodes were placed on her scalp, sensors along her chest, tiny speakers fitted into her ears, sealed tight, delivering clicks, sharp, repetitive tones designed to measure whether sound could still be processed. Soon, even that would go silent. As anesthesia flowed, the world did not fade all at once. It narrowed. The edges softened first. The ceiling lost depth. Faces became shapes. Then even shapes let go. The body went still. Later, doctors would say this with precision. They would say her blood was drained from her head, that her temperature was lowered to levels incompatible with conscious life, that the electrical activity of her brain flattened into a line so quiet it could not be mistaken for sleep. No signal. No response. No measurable awareness. Clinically, she was gone. And yet, Pam would later describe a moment that did not fit anywhere on the chart. Not darkness. Not a dream. A separation so clean it felt surgical in itself. She was no longer inside the weight of her body, no longer behind her eyes. She was above, near the ceiling, slightly offset, as if positioned where a camera might be placed to see the whole room without being seen. The first thing that caught her attention was not fear. It was an object, a tool. It looked, she would say, like an electric toothbrush. That comparison came easily to her, not because she was minimizing it, but because she recognized the shape immediately. Short, metallic, with a narrow shaft and a head that did not belong in a bathroom. She noticed how it was held. She noticed who held it. She noticed what happened just before it touched bone. These were not impressions. They arrived as observations, discreet, orderly, strangely calm. There was no sense of floating away into light, no voices calling her name, no emotional crescendo, just a room, a procedure, a sequence unfolding exactly as it was meant to. She watched as her skull was opened, not with horror, with attention. From where she was, she could see angles the patient on the table could never see. She could see hands move in coordination, hear comments exchanged that were not meant for her, notice details no one had explained to her beforehand, details that had no reason to be remembered later, because later was not supposed to exist. In that moment, there was no thought of survival, no internal narration saying, "This is impossible." There was only the quiet certainty of presence. She was there, and her body was not. The monitors continued their work. The instruments continued their rhythm. The room continued to function as if consciousness had been successfully removed from the equation. Nothing in the protocol allowed for a witness. Yet one remained. Pam did not try to interfere. She did not attempt to speak. She did not wonder how long this would last. Time itself seemed irrelevant, stretched thin, no longer marked by seconds or heartbeats. The only thing that felt unusual was how ordinary it all seemed, as if awareness, once freed from the constraints of flesh, did not become extraordinary, but simply unburdened. Somewhere below, her brain lay inactive, silent, unrecording, and still the watching continued. This is where the story begins. Not with a miracle, not with an explanation, but with a woman, clinically dead, calmly observing the precise moment her own life was being placed on pause. From where she was, the room had no center. There was the table below, her table, but it did not pull her attention the way a body normally does. Gravity felt optional. Distance felt negotiable. She drifted, not aimlessly, but without resistance, as if intention alone determined position. She noticed sound next. Not the beeping she would later be told was impossible for her to hear. Not the clicks pulsing into her ears. Those had already lost their purpose. What she perceived was conversation. Voices layered with familiarity and focus, clinical, efficient, unembellished. One voice, in particular, stood out. Calm. Confident. The kind of voice that does not rush because it has done this before. She recognized it. Not by name, by tone. She watched as the surgeon spoke to someone just outside her field of view. The words were ordinary, instructions, timing, a remark about the exposure. Nothing poetic, nothing dramatic. Yet they stayed with her. Because later, when her body returned, those same words would surface intact, out of place, unexpected, unchanged. The tool came closer. From above, she could see the way it was connected. The thickness of the cable, the angle of approach, the way the surgeon adjusted his grip just before contact, as if responding to a subtle resistance she could not feel from where she was. When the instrument touched bone, she did not flinch. There was no pain to escape from, no reflex to override. The sensation was informational, not physical, like watching a process you understand without participating in it. She registered another detail. A case, a container. It was opened briefly, then set aside. Inside, she noticed something she would later struggle to describe, not because it was vague, but because it was in a way that felt unreasonable to remember. A shape, a color, a placement that seemed trivial until it wasn't. She wondered, briefly, why she was noticing such small things. The question did not linger. Her attention shifted again, drawn by movement near her legs. A nurse adjusted something at the foot of the table. The gesture was quick, habitual, easily overlooked. Pam did not overlook it. She noticed the position of the nurse's hands, the way the fabric of the gown folded, the slight pause before the nurse stepped back into place. From below, none of this would have been visible. From inside the body, impossible. But she was not inside. She was not anywhere that could be named. At some point, she would never be sure when, the room no longer felt like a room. It expanded, not outward, but conceptually, as if the boundaries that defined here and there had thinned enough to let context bleed through. She became aware of something else. Not a presence, not a being, a shift. The sense that attention itself was moving, away from the surgical field, away from the choreography of hands and tools, towards something that did not resemble a location. There was no tunnel, no flash, just a gentle reorientation, like turning your head toward a sound that has always been there. And then she was somewhere that felt unmistakably right. Not emotionally overwhelming, not euphoric, simply aligned. As if every part of her that had ever been tense had quietly agreed to rest. She felt accompanied, not surrounded, not addressed. Accompanied, in the way silence accompanies music, by presence rather than interruption. Images surfaced, but they did not behave like memories. They did not arrive in sequence. They did not demand interpretation. They existed simultaneously, without competing for importance. A landscape, though not a place. A familiarity, though not recognition. A knowing, though not information. She did not think, I am dead. The concept had no relevance there. What she did think, if it could be called thinking, was that whatever she was experiencing did not require a body to sustain it. That realization did not feel revolutionary. It felt obvious. Then, just as gently, the orientation shifted again. Not abruptly, not forcibly, more like being reminded of something unfinished. The room reassembled. The lights, the table, the instruments, her body, still inert, still silent. She felt herself descend, not downward, but inward, toward weight, toward density, toward limitation. The return was not painless. But pain was not the first sensation. Sound was. A sharp, intrusive tone forcing its way into awareness. The clicks in her ears, mechanical, insistent, reasserting their presence. The body registering inputs again, one system at a time. Then pressure. Then cold. Then the undeniable fact of having a face, a chest, a pulse. Consciousness did not arrive all at once. It layered itself back into place, unevenly, reluctantly. When she opened her eyes, the room was no longer abstract. It was real again. And something else was real with it, the memory. Not fragmented, not dreamlike, complete. She did not yet know that what she remembered should not have been possible. That realization would come later. For now, there was only the lingering certainty that she had been present when presence was not supposed to exist, and that she had seen things she had never been meant to see. The first time Pam spoke about it, she did not lead with wonder. She led with details. Not feelings, not meaning, details. She described the tool again, the one she had compared to an electric toothbrush. She described its size, the way it was held, the moment it was brought into the field. She mentioned a case that had been opened briefly. She mentioned a remark spoken by the surgeon, casual enough to be forgotten, precise enough to be verified. Those listening did not interrupt her. They waited. Because this was not how patients usually spoke after major surgery. Not with lists. Not with specificity that resisted interpretation. When she described the surgical sequence, the order mattered. She did not compress it into a single event. She separated moments that, to an observer on the table, would have blurred into nothing. There was the preparation, then the incision, then the instrument, then a pause. That pause drew attention. In the operative record, there was a pause, a brief delay, before a step that could not be reversed. Pam had mentioned it without knowing it existed. Someone retrieved the surgical notes. Another checked the timing logs. The procedure had been documented in a way that left little room for ambiguity. Times were recorded. Steps were marked. Monitoring data ran continuously. During the interval Pam described, her brain activity had not merely slowed, it had ceased. The EEG showed no cortical response. The auditory-evoked potentials, measured through the clicks delivered into her sealed ears, showed no signal reaching the brainstem. Her eyes were taped shut. Her body was immobilized. Her blood had been drained from her head. There was no sensory pathway left intact. And yet, Pam had described the room, not abstractly, spatially. She had described where people stood, what they did when they were not performing the primary task. A nurse adjusting something near her legs, an object placed briefly on a surface, then moved. One of the staff members remembered that moment. Not because it was dramatic, but because it was routine. The kind of thing you don't expect anyone else to notice. Another detail followed. Pam mentioned something that at first no one knew how to place. A sound. Not the clicks, not the monitors, a comment spoken offhand, not directed at her, not amplified. When the surgeon was asked about it, he paused, then he nodded. He remembered saying it, not loudly, not for effect, just something said while working. The room, he explained, would not have carried that sound to a patient under normal circumstances, especially not one with her ears sealed and her brain electrically silent. No one said this shouldn't be possible. They didn't need to. The records spoke their own language. Physiological markers, timestamps, temperature readings, all consistent, all incompatible with perception. As the account circulated among clinicians, the tone shifted, not toward belief, not toward dismissal, but toward something quieter. Attention. Questions began to form, not about Pam's interpretation, but about the alignment between her recollection and the documented sequence of events. Each match tightened the space, not dramatically, incrementally, the kind of tightening that happens when coincidence runs out of room. The breaking point did not arrive with a single revelation. It arrived with accumulation. A list of things Pam could not have known, a list of things she knew anyway. By the time the comparison was complete, no one in the room was arguing about what she felt. They were looking at what she reported and what the instruments had recorded. The gap between the two did not invite explanation. It invited silence, because silence, in that moment, felt more honest than certainty. Pam was never asked to defend her experience. She was asked to repeat it, and each time, the structure remained intact. The same sequence, the same details, the same calm delivery. Not embellished, not revised, just stated. By then, the story no longer belonged only to her. It belonged to the records, and to the uncomfortable realization that, for a measurable span of time, awareness had left no measurable trace. yet left behind a trail of accurate observations. That was the point where the room changed again. Not the operating room, the room where certainty usually lives, and where, on that day, it quietly stepped aside. After the story settled, something quieter began. Not answers, not conclusions. Comparison. Pam Reynolds' account did not exist in isolation. It was placed beside timelines, charts, surgical protocols, and physiological thresholds. Not to challenge it, but to see where it overlapped with what medicine already understood, and where it didn't. In operating rooms like hers, awareness is not guessed at, it is measured. Electrical activity, auditory pathways, reflex arcs. The conditions of her surgery were chosen precisely because they removed ambiguity. Hypothermia slowed the brain. Circulatory arrest emptied it. Monitoring confirmed silence. This was not anesthesia drifting too lightly, not partial sedation, not dreaming under stress. By design, there was no room for perception, yet perception was reported. That tension between protocol and report did not demand a leap into belief. It demanded restraint. Researchers described the case carefully. Words like suggests replaced words like proves. Questions were allowed to remain questions. Could residual brain activity explain it? Some proposed that awareness might flicker at levels too subtle to register, but the data resisted that comfort. Auditory evoked potentials, specifically designed to detect even minimal processing, showed nothing. The timing of Pam's observations aligned with the deepest point of shutdown. Could memory reconstruction fill the gap? The problem was sequence. Pam did not reconstruct the surgery as a narrative whole. She recalled fragments that matched moments she had no access to, details too specific to be inferred after the fact, too mundane to be guessed. Could coincidence account for it? Coincidence has limits. Not philosophical limits, statistical ones. As matches accumulate, coincidence does not disappear. It simply stops being sufficient. Still, no one said therefore. What emerged instead was an insight shaped more by humility than certainty. If consciousness is entirely produced by the brain, then the brain's silence should imply its absence. Pam's case did not overturn that model. It unsettled it. It suggested that our measurements might not fully capture what they intend to measure. That awareness might not behave like a switch, on or off, but like a process that can disengage from the structures we associate it with. Or it suggested something else, something harder to frame. Pam herself did not campaign for interpretation. She did not insist her experience meant one thing or another. She described what happened. She allowed others to struggle with its placement. Over time, the case found its way into discussions of near-death experience research. It was cited cautiously, often with footnotes, sometimes with discomfort. It became a reference point, not because it explained anything, but because it refused to fit cleanly into existing explanations. Years later, the instruments used in her surgery would be upgraded. Monitoring would become more precise. Models of consciousness would evolve. New theories would offer new language, and still, her account remained unchanged. A woman, clinically dead, describing a moment when observation continued without a functioning brain. No proclamation followed, only a pause. Because some stories do not ask us to choose what to believe, they ask us to notice what we cannot yet explain, and to leave space for what that might mean. If awareness can persist when the brain is silent, even briefly, then the boundary between life and death is not as sharply drawn as we assume. And if it cannot, then we are left with an equally unsettling question. Why did Pam Reynolds see exactly what she should never have been able to see? The instruments fell quiet. The charts closed. But the question did not.